Greetings from eMedi News and Heart Care Foundation of India. The topic we are going to discuss today is liver transplantation. Over 2 lakh people suffer from liver diseases in India, and approximately 20,000 of them need a liver transplant, but only 700 get it. Why this is happening? Why can't we have liver transplant units all over the country? Why can't cadaveric transplant be available to every person? Why should people die for want of a liver transplant? This is what some of the questions we'll try to answer today. And with me is one of the experts in liver transplant. Let me introduce her, Dr. Neelam Mohan. She is a director of pediatric hepatologist and a transplant physician at Gurgaon, the Medanta, the MedCity. Welcome, Dr. Neelam.
Thank you so much.
When we talk about liver transplant, why liver transplant is so important? In fact, what is liver transplant?
Well, liver transplant means replacing your liver with a new liver. That is, in simple words, I can say that that's what liver transplant is about. And why do you need liver transplant? Is when the liver is not working to its optimum efficiency, then you need a liver transplant. God has been very kind. Most of the time when you get into end-stage liver disease, the reserve that your liver has got is nearly 70% more than what you need actually. So when you will ultimately need a liver transplant, it's when nearly 70% of your liver is damaged. That is when you need a liver transplant for most of the indications, like in end-stage liver disease or even in acute liver failure where that much of the liver is damaged.
That means a part of the liver of the recipient is taken out and it is replaced by a part of the liver from the donor.
No, actually the whole liver of the recipient is taken out and thrown, and then a part of the liver or a whole liver can be inserted in its place, depending on where you get the liver from. Now, that was a very interesting question that you raised. There is an entity called auxiliary liver transplant, which we don't routinely talk about. That is indicated when you have an acute liver failure or some enzyme is deficient in your body, but the rest of the liver is efficient. Say like in Crigler-Najjar, where you just need one enzyme. In that, what you do is you may not take out the whole liver from the body of the recipient. So you take out, you give a part of the new liver to that body. That is when you got auxiliary. But for practical purpose, when we talk about liver transplant, the truth is we remove the entire liver out and place a new liver.
The liver which I have taken out from the recipient, can it be used for somebody else?
Yes, in very rare situations you can. Because when we talk about indications of liver transplant, we usually talk about the end-stage liver disease as well as the acute liver failure. There is a small proportion of the group that would require for inborn errors of metabolism. That is, the body is deficient in a particular enzyme, and that's when you need like maple syrup urine disease, organic acidemias, urea cycle defects. These are rare conditions where one enzyme is deficient in your body. For example, in maple syrup urine disease, the enzyme is present all over the body, and liver has got say 12% of it. So when we give a new liver to that child or a patient who needs a liver transplant, the liver that is taken out from the body is otherwise very good, and it can be given to a non-MSUD patient because that patient would have more than 80-85% of the enzyme in the muscles and other organs. So this is called domino liver transplant, which very few have done, and I was lucky to be involved in the world's youngest domino liver transplant, where we took the liver out of a 2-year-old maple syrup urine disease patient and gave it to another patient who was suffering from sclerosing cholangitis and Langerhans cholestasis induced cirrhosis.
Let's talk about common conditions where do we lead in liver. Say in acute hepatitis, acute inflammation of the liver, so-called routine jaundice.
Right.
In which conditions liver transplant is required? Because that's one condition where people are scary.
Right.
Where people are thinking that why should I need a liver? I only have a simple jaundice.
Perfect. Now this is very important to understand. To begin with, I said that liver has got nearly 70% more reserve. But that 70% is in a healthy, normal liver. Now, it depends. Somebody who's an alcoholic or somebody who's obese, who's got fat. So, that fatty liver is not working. So, if a person has 30% say fatty liver, so he's already compromised liver, so 30% was gone. And now he develops a jaundice. And so, the reserve that he would have would be only 30%. And when the 30% gets knocked, he's going to get knocked out. So, people think that, you know, they do all this various things to treat a jaundice, but the truth is there's nothing that you're doing except giving some supportive vitamins and etc. that you want the liver to regenerate. But in a small proportion, when the liver is not able to regenerate and the damage is extensive, it has gone into necrosis extensive, that is when you need a liver transplant, and that is called as liver failure. So the liver copes up in the routine jaundice hepatitis that you talk about, but when it gets into liver failure, that is when you need. But that doesn't mean all patients who get into liver failure need a transplant. Even in liver failure, there are certain criteria that you have to match about, and then from then on you talk about the transplant. Now that you raised a point, I will talk about it. I was just seeing this Amir Khan interview that day, and I just saw a couple minutes of it. And there was this young girl who was saying that my father was asked to do a transplant, and one doctor referred and he said you need it, and the other doctor said you need it, and my family physician came and he said isko to gastroenteritis ho gaya, he doesn't need. Now, I don't know the entire story about it. What I can understand, gastroenteritis, hepatitis A is what? It is a foodborne infection. So I'm assuming maybe it was a foodborne infection where the patient had hepatitis A, and when you get into liver failure, a normal, nobody can be 100% sure. We can give you 95%. So when do we suggest a transplant is when the probability of that patient surviving with the native liver is less than 95%. 5% nobody can be guaranteeing you. So maybe he had liver failure and therefore he was suggested, but his liver failure, that 3 to 5% he must have recovered. And she said he's like 7 years down the line. So this is what I want people to understand, that somebody, when they say liver transplant in a patient with his liver failure.
When we talk about liver failure, it's not synonymous with hepatic encephalopathy. That means you can have.
Well, you are right to some extent. Hepatic encephalopathy is a component of liver failure.
So all patients with the liver failure who will require a transplant will be encephalopathy?
Not necessarily.
Not necessarily.
Because the two important indicators that we talk about is coagulopathy and encephalopathy. It is true, majority of the patients who get into coagulopathy will have encephalopathy, but it is not required that all patients of encephalopathy will need a transplant, and it is also does not hold good that all patient who needs a liver failure will get into, they will get into hepatic encephalopathy. What I mean to say was, maybe there would be grade 1 or 2 which, you know, a normal individual may not ask. When you talk about hepatic encephalopathy,
I'm talking about a general physician, a general practitioner.
Right.
How would he know if he's managing at home? The patient is fine, bilirubin is rising, SGLT, SGPT are more than thousands. At what time he will come to know that this patient may require a liver transplant?
See, I would suggest that when your bilirubin is more than 15, or though the criteria is 18, but to be safer side, you take something which is more than 50, or your enzymes are in thousands, or a scenario where the bilirubin is rising and the enzymes are getting down. And the most important of all is the physician should monitor a prothrombin time. When the prothrombin time is the main index which tells us the synthetic function of the liver. So if the prothrombin time is rising, or the INR that you might call, if that is going beyond 2, then that is a patient who's getting into liver failure. Then after that, it is better to refer to a specialist, because a specialist is that patient needs to be admitted beyond doubt.
So a bilirubin more than 15 and INR more than 2 means admission.
I would 100% endorse that.
And at what step now the patient is admitted under a physician? From a GP, it has been transferred to a physician. From a physician, when he should go to a hepatic
well, I think when the patient is in a liver failure, I would definitely want a hepatologist to see, because as I said, all patients who get into liver failure do not need a transplant. If you efficiently manage the patient, for example, in my setup, I've had children where 60% or probably it was 64% that in our data that we were talking about, liver failure patient did not need a transplant. They could be managed with an efficient system. The way you have to manage this patient is literally like a hawk. You know, you have to be putting them on a ventilator once they get into grade 2, and you know that's a different story. But you don't need transplant for all liver failures.
Now we go back from acute hepatitis to acute drug-induced hepatitis. Suppose we have acute drug-induced hepatitis. Again, SGOT, SGPT will be in thousands. Patient bilirubin will be rising.
Well, majority of the time in the drug-induced hepatitis, it is assumed that the liver, you need to support the liver for the liver to regenerate, as I said, depending on the percentage that it is dormant. Suppose it is an extensive damage and the INR, the prothrombin time has gone more than 6. It is usually said that when the prothrombin time is more than 100 seconds, you know, it's a virtual death. You will have to suggest a liver transplant when it goes that bad, because you will not get time at all to salvage that liver. But if you think your INR is lingering, say around 3.5, so there are certain criteria that we take, which is called as the King's College criteria and the Clint Cheese criteria. So these are the criteria where we monitor the factor 7, we monitor the prothrombin time, the creatinine, as well as, so we look into certain criteria for an individual and decide. But in India, most of the time, the drug-induced liver failure that we see are the paracetamol and the valproate toxicity. Sorry, not paracetamol, I wanted to say the tuberculosis one. The paracetamol is more common in the West, which fortunately in India people are not aware.
Is there any reason why? Because in US they say that #1 cause of suicide is paracetamol. Not there in India.
Well, in India you get anything.
I hope people don't listen to us.
Well, in India you get anything over the counter and they find probably better ways of committing suicide rather than taking paracetamol. So that is true. You don't see paracetamol induced poisoning so much.
But then antitubercular drugs can cause hepatitis to an extent that you need a liver transplant?
Yes. In my experience, I've had 2 instances where we had to do with antituberculous drug transplants. But yes, if you give them efficient supportive management and you stop the drugs and you monitor them, you might be able to salvage that.
Is there any role of liver transplant in ischemic hepatitis? Again, SGOT, SGPT more than thousands.
Well, as you said,
they will recover.
They usually, for example, in dengue, when we talk about the gold standard is that you have to look about the prothrombin time. If it goes beyond INR 6 or beyond 100 seconds, then you will need a transplant. But what happens usually in the ischemic hepatitis, these patients are in shock and there's multi-organ failure. So when there is multi-organ failure, that itself is a contraindication to the liver transplant.
So let me come back to a very important point is that prothrombin time more than 3 refer, and if prothrombin time is more than 6 or if it is more than 100, then you have to really send it to a transplant physician for an opinion.
Right. The INR, if it goes beyond 1.5 to 2, please ensure that the hepatologist is involved. The hepatologist is going to admit that patient if it is an acute condition. Sometimes in chronic liver disease, you might like to sit over that depending on how the patient progresses. Then the hepatologist will refer to a transplant physician if the INR is going beyond 3 or there is the rising bilirubin and the encephalopathy is setting in, then the transplant hepatologist
when do we need transplant in chronic liver disease? I'm talking about fatty liver, I'm talking about alcoholic liver, I'm talking about cirrhosis of liver, all I'm talking together.
Right.
When do we need a transplant?
Well, you need, again, the simple dictum, you need a liver transplant in chronic liver disease when the liver fails. That's called chronic liver failure. And in cirrhosis, there are 2 types. One is a compensated cirrhosis. As the name indicates, the liver is scarred, so there is cirrhosis. But despite that, the body is trying to compensate for that part and work overtime over it. And so your synthetic functions like the INR and the albumin are maintained, so you would, wait. When you call it decompensated is when the prothrombin time gets deranged, the albumin gets deranged, you start having effects on the, say, kidney in some of these conditions, your hepatorenal syndrome, and there is recurrent ascites due to portal hypertension and SBP and varicose bleeding, etc. Then it is better to get into transplant. And one more important message I would like to give is, when you think your patient is decompensated and needs a liver transplant, then there is no point postponing it too much. In the West, it is predominantly a cadaveric transplant, where we'll discuss about that. So, you know, they put them on the waiting list, but by the time you get the liver, the patient might deteriorate and the success of a transplant decreases. So, if your patient is decompensated and you need a transplant in a setting which is living related transplant in India, there's no point postponing it too much.
So for
because you need some, even for a hernia surgery, you need some, a fitness.
So in acute liver disease, we are talking about prothrombin time.
Yes.
In chronic disease, what are we talking
Same,
about?
synthetic functions we talk about.
Again, prothrombin time or?
No, it depends the type of, if it's a cholestatic liver disease and a non-cholestatic liver disease. So there are three components to it. In a cholestatic, it's usually the bilirubin that we are chasing, and the synthetic function is the prothrombin time and the albumin. So that talks a lot about the synthetic function, which sometimes may not be very bad in cholestatic liver disease, but they have a lot of issues because of itching, pruritus, quality of life, etc.
I can call it as a decompensated liver failure.
Yes, and the third would be the portal hypertension and its issues.
Yes, they are all really signs of decompensation.
Right.
Apart from that, are there any other conditions where we use liver transplants, say liver tumors and other?
Yes, besides the acute and the chronic that you talked about, you need it in patients who have liver tumors. These liver tumors could be either malignant tumors or a large benign tumors where the entire liver is involved, and sometimes the inborn errors of metabolism in children where because of the metabolic
say out
disorders,
of 100 liver transplant, just give me the statistics. That how many liver transplant will be in acute condition, how many in chronic conditions?
Right. Let's divide it into the children and the adults. In the children, majority of the time, the chronic liver disease is biliary atresia. They constitute nearly the 60% of our etiology. The metabolic liver diseases are 20 to 30%, and very small proportion, 10% to 15% are due to liver failures. In the adults, the liver failure also constitute around 15 to 20%, and they have more of an alcoholic liver disease and chronic hepatitis B, C, fatty liver, and biliary cirrhosis.
How many people with liver tumor will end up into liver transplant? Say in India, suppose we
yes, in liver tumors in adults, they constitute quite a lot, especially when they talk about the hepatitis B and C. I think it would be more than 10%.
And inborn error of metabolism?
It's a very small proportion. I would say less 3 to 4% maybe.
What we have learned today is that liver transplant is now a reality in our country. It's possible 600 to 700 liver transplants are done every year, though the requirement is more, but the number is gradually increasing. More and more centers are coming. For a general practitioner and for a physician, they should remember that if they see a acute liver disease with progressively increasing prothrombin time, rising bilirubin, or patient going into a hepatic encephalopathy, or a patient with a chronic liver disease showing signs of decompensation, the patient should be referred to a specialist, and every specialist should also think of referring it to a transplant specialist so that a timely intervention can be done. And remember, transplants is now a reality in our country, and it's possible to save lives. That's all for today. Thank you very much. Thank you, Dr. Neelam, for this.
So much.
We'll come back with one more edition and some other aspects of liver transplant again. Thank you.